So, welcome to this NEET SS 2023 recall session of cardiology. So, again, the exams are over. I'm sure that most of you have done very well in your exams. So, on recalling at least the cardiology part of the question paper, I got an idea that it's a very difficult paper. And the main reason it was difficult is there are a lot of factual questions. That is, you either know the answer or you don't know the answer. Okay, for example, treatment of Coxiella burnetii infective endocarditis. Okay, you cannot guess the answer out. Okay, so usually in the previous NEET question papers, they used to give you a case scenario and you could maybe eliminate a few options, but here it was purely factual questions. Questions were being asked from unusual areas. So I have written competitive exams from cardiology for the past, I've gone through the papers for the past 8 years. So I got a sense that questions were being asked from certain unusual areas and there were less clinical scenarios. Around 19 questions were asked from cardiology. Around 1 to 2 of this was related to cardiology, but I don't feel it's from cardiology, but I've included them in this discussion also. So the first question is treatment of choice for Coxiella burnetii infective endocarditis. Again, this is from an unusual area. So far, I've never seen a question being asked from Coxiella burnetii infective endocarditis. The answer is doxycycline plus hydroxychloroquine. Again, this is from Harrison. So you can see addition of hydroxychloroquine to doxycycline. Okay, so you get doxycycline 100 milligrams BD with 200 milligrams TDS of hydroxychloroquine. So again, unusual areas. The standard question is usually treatment of HASAC infective endocarditis, which is ceftriaxone. First time I'm seeing this question. Next question, again, another unusual area. First trimester benzodiazepine congenital defect. So they're asking the teratogenicity of benzodiazepine. Again, I've never seen this question in all of the competitive exams I've gone through. So again, the answer is cleft lip. Okay. So again, you can see this here, benzodiazepines and barbiturates, cleft lip and cleft palate are your commonest things. So again, coming back here, so again you can see ASDs, the teratogenic defects of ASDs we have covered. Epstein's is basically lithium. Pulmonary stenosis, lot of associations they've also covered that. This we have not covered because again unusual areas. Next is hyperkalemia ECG findings all are true. Again, this is a controversial question. Okay, ST depression, tall T wave, short QT, PR increased. Okay, the answer is ST depression. Okay, according to me, all four are seen in hyperkalemia. Okay, it depends on your reference. Okay, remember tall T waves, all of you know it's due to hyperkalemia. Short QT again seen in hyperkalemia. Increase in PR again seen in hyperkalemia. ST elevation in V1 and V2 is characteristic of hyperkalemia. It's characteristically seen. Again, we have described that in the last last NEET SS recall. ST depression also is mentioned in some books. That's why I said it's controversial. But again, I've taken a reference from Balthazar. Again, I consider Balthazar a book which every MD-PG must read. So mild hyperkalemia, peaking of T waves, QT might be shortened. Moderate hyperkalemia, more peaking of T waves, QRS widens, P waves become broader and its amplitude decreases, PR prolongs. And severe hyperkalemia, you have absent P wave, broadening of the QRS complex, you have the sine wave pattern, ST elevation in V1, V2, asystole and ventricular flutter. Hyperkalemia is called the syphilis of ECGs. So previously, he who knows syphilis knows medicine. Similarly, he who knows hyperkalemia will probably know ECG. Many books or many articles have also described ST depression to be seen in hyperkalemia. But again, if you have to choose one, you have to mark ST depression. So let's go for hyperkalemia's ECG findings. Okay, so this is your QRS complex. So this is repolarization and this is depolarization. So for this, for understanding the ECG findings of hyperkalemia, you need to know that hyperkalemia causes abnormally fast repolarization and causes an abnormally slow depolarization. So hyperkalemia causes an abnormally fast repolarization and an abnormally slow depolarization. So this part becomes shortened. So repolarization shortens. So as a result, your T wave becomes more prominent as it shortens. Your QT shortens. Remember, your QT is going to shorten. Okay, your ST segment shortens. Okay, this part widens. So you have your QRS widening, you have your PR widening, your P wave also widens, it becomes flattened and decreases in amplitude. P wave widens and decreases in amplitude. So you can understand the features of hyperkalemia by this. Abnormally fast repolarization, abnormally slow depolarization. So remember, T as the repolarization shortens, T wave increases, ST segment shortens, QT shortens. Depolarization widens, so QRS widens, PR widens, P wave becomes stretched out, becomes decreases in amplitude. This is how you remember this. Hypokalemia is characterized by abnormally slow depolarization, abnormally slow repolarization. Both are slow. You can guess the ECG findings with the help of that. So again, it was a bit controversial because there are articles and books which mention ST depression. But again, the other three are very classic and ST elevation is known to occur. So I would mark it as ST depression, but it is a controversial question. So again, this is some of the ECG examples I have with me. So you can see the ST elevation in V1 and V2 in hyperkalemia. In this case, the potassium was somewhere near 8. This is a CKD patient who skipped dialysis. Okay, this is your broad, it's a ventricular, idioventricular rhythm. It's a very broad, complex idioventricular rhythm. There is no P waves here. Okay. So again, this is just the ST elevations in V1 and V2 you can see here. So coming to the ECG findings, you can see prominent T waves here in all leads. You can see prominent T waves. You can see some sort of ventricular rhythm, idioventricular rhythm going on here. The QRS has started to widen. You can see no P waves occurring here. And finally, you can see the ST elevation in V1 and V2, classical of hyperkalemia. Again, this patient had a CKD, had skipped dialysis, his potassium was somewhere near 8. So, 76-year-old female, acute onset of dyspnea, chest pain and palpitations. On auscultation, there's an ejection systolic murmur on the left sternal border, increasing on standing and decreasing on squatting. They showed a moving picture of an echo. Again, I don't have that echo. So I'll come back to the echo later on. So 76-year-old female, dyspnea, chest pain, palpitation. ESM on the left sternal border, increasing on standing, decreasing on squatting. What are we dealing with here? We are dealing with a dynamic LVOT obstruction. Okay. So remember, it's an ejection systolic murmur in the left sternal border. That is a LV outflow murmur. It is increasing on standing, decreasing on squatting. Again, these are features of what? These are features of hypertrophic obstructive cardiomyopathy. Okay. Why is this patient having acute dyspnea, chest pain and palpitation? Probably this patient has gone in for atrial fibrillation. And atrial fibrillation in HOCM is very poorly tolerated. So please have a look at in the modules why. So again, HOCM because of the LVOT murmur increasing on standing and decreasing on squatting. Why is the patient symptomatic acutely? Because this patient had developed AF. Again, it will not be controversial, but from what I got, the feedback from the students is the echo showed concentric LVH with biatrial enlargement. So that is what got people confused, and they went and marked restrictive cardiomyopathy. Again, it's pretty clear. It is HOCM. The clinical features are very clear. Why should restrictive cardiomyopathy cause an outflow murmur? Okay, again, which worsens on atrial fibrillation. So again, I don't have the echo image available, but from the clinical features, I would safely mark this as hypertrophic cardiomyopathy. Okay, I would not even consider restrictive cardiomyopathy in this differential diagnosis. RCM does not produce an LV outflow murmur. Then some people said that this could be RCM with an acquired LVOT obstruction. Again, I feel it is a bit far-fetched. There are certain causes of acquired LV outflow tract obstruction. RCM is not among them. Okay, Takotsubo causes an acquired LV outflow tract obstruction. MI causes an acquired LV outflow tract obstruction. Or when you have an elderly with very thick LVH, you are giving inotropes, patient is dehydrated, you can get an LV outflow tract obstruction. RCM is not among them. So even without looking at the echo, I think you should consider HOCM as the diagnosis. Another controversial question. So 3 controversial questions. I'm trying to get out all the controversial questions fast. So chest X-ray findings of rheumatic tricuspid stenosis. Okay. So it's either dilated RA with a normal pulmonary artery. So again, when you have tricuspid stenosis, your RA is going to enlarge. I made a statement in my videos. Isolated RA enlargement is seen only in two conditions. One is TS and one is Epstein's anomaly. TS never exists in isolation. It is almost always seen with MS. So that is why it is almost the isolated RA enlargement is seen only in Epstein's. Okay, so it's either dilated RA with a normal pulmonary artery or biatrial enlargement. Again, it depends on what your examiner thinks. Okay, if the examiner thinks that TS can only exist with MS, then the answer is biatrial enlargement. If the examiner wants only the findings of rheumatic tricuspid stenosis, isolated TS, again, it's almost unknown, then you mark it as dilated RA with a normal pulmonary artery. Again, you can argue till the sun comes down, but ultimately, please know the what underlying mechanism. Okay, so remember, isolated RA enlargement is seen only in TS and in Epstein's. Isolated TS is almost unknown, so it's actually only Epstein's. Okay, so the next controversial question. So we are finishing all the controversial questions. 46-year-old patient with recent MI 2 months ago underwent PTCA. Patient is on dual antiplatelet therapy. Patient has a history of colorectal cancer. Patient wants to undergo screening for colorectal cancer. What to do next? Okay, so this patient who has had an MI 2 months ago, patient is on DAPT. Right now, patient wants to undergo a screening procedure, maybe a colonoscopy. So what is the what to do next? The answer is don't do colonoscopy. Okay, that's a very safe answer to give. Okay, don't do colonoscopy. The controversy comes is whether polypectomy was mentioned or not in the option. So if polypectomy was mentioned, the answer completely changes. But the consensus was the patient whether to do colonoscopy or not. So remember, 46-year-old patient had an MI 2 months ago, wants a screening procedure. Now remember, this patient is not symptomatic. It's just a screening procedure. So you can defer the screening procedure for 1 year. So the answer is don't do colonoscopy until 1 year. So this gives us a good chance to understand the latest antiplatelet strategy for patients on stents. Okay. For stents per se, so if you are putting a drug-eluting stents, there is no more bare metal stent. Okay, since 2007-8, there is no more bare metal stent. We always discuss drug-eluting stent. For a drug-eluting stent, you require DAPT only for 6 months. It is assumed that your stent gets endothelized. For an MI patient, you require DAPT for 12 months, 1 year. Okay, irrespective of whether you conservatively manage the MI, you lyse the MI, or you do a primary angioplasty, MI itself is 12 months. So remember, if you put a DES, you require antiplatelets only for 6 months. If it's an MI patient, whatever method you manage it, you require it for 12 months. Let's say for an MI, you do a PCI. Okay, for this you require DAPT for 12 months. It is not because of the stent, it is because of the MI you require DAPT for 12 months. You must understand this. Okay, for a primary PCI, because you did it for an MI patient, you require 12 months, not for the stent. For the stent, you require only for 6 months. But because it is for an MI patient, you require it for 12 months. The latest antiplatelet guidelines have changed. We are following the ESC 2022 guidelines. Brongall gives you the ACC 2016 guidelines. So elective non-cardiac surgery after PCI should be or ACS should be there for 6 months after elective PCI, 12 months after ACS. This is what I just explained. So for elective, suppose you are doing a PCI for chronic stable angina, DAPT of 6 months only is required. You're doing a PCI for an MI patient or any MI, lysed MI, medically managed MI, it's always 12 months. If this is a hernia surgery, you can obviously postpone. Okay. If it is a hydrocele surgery, you can obviously postpone. What if you cannot postpone the surgery? So we'll be discussing the latest ESC 2022 guidelines. So what if you cannot stop the antiplatelets? Okay. So suppose the patient is on DAPT and the surgeon feels that he can do the surgery despite the patient being on both aspirin and clopidogrel, for example. You can straight away continue the DAPT. Let's say the patient is undergoing a cataract surgery, a low risk surgery. You need not stop the DAPT. Risk of bleeding is minimal. So straight away you can do the surgery on continuing both aspirin and whatever P2Y12 inhibitor. The problem comes is suppose the patient has a surgery where you require to stop the antiplatelets. That's when the controversy comes. So high bleeding risk for the surgery. Let's say the patient is undergoing an appendicectomy surgery, high bleeding risk. Okay. If the PCI is done, the cutoff is PCI of less than 1 month or ACS of less than 3 months, or if the patient is at high risk for stent thrombosis. So these are your cutoffs. If the PCI is less than 1 month, let's say a PCI for a chronic stable angina, or the ACS is less than 3 months. Okay. In that case, you can either try to defer the procedure, or if the procedure cannot be deferred, you stop the antiplatelets, you give cangrelol, okay, cangrelol or eptifibatide, which are shorter acting antiplatelets, till the surgery, stop the drug and then do the surgery and then restart the antiplatelets. So very important thing for you to know. For a height, otherwise, so let's look at the ESC 2022 guidelines when you have to stop antiplatelets prior to the surgery. So this is the ESC 2022 guidelines. If the patient does not have a high bleeding risk, for example, it's a cataract surgery, the surgeon is very confident that he can do the surgery on both antiplatelets, you can straight away ask the surgeon to do the surgery. For example, minor surgeries like cataract surgery, IND, okay, these can be done without stopping antiplatelets. So if the surgeon feels that he can do the surgery, continuing aspirin and clopidogrel, you can straight away do the surgery. The problem comes is when there is a high bleeding risk. For example, you are doing an intra-abdominal procedure like appendicectomy. It's difficult to do it on both antiplatelets. Okay. So in that case, the cutoff is PCI of less than 1 month or ACS of less than 3 months, or patient is at high risk of stent thrombosis. So suppose you are doing a PCI for a chronic stable angina. So less than 1 month or an ACS of less than 3 months. Okay. If it is so, try to defer the surgery. If you cannot defer the surgery, what you do is you stop the aspirin and clopidogrel, you start the patient on eptifibatide or tirofiban infusion or cangrelol infusion, which are short acting antiplatelets. Go till the surgery, day of surgery, do the surgery and then start the antiplatelets back again. Suppose it is the duration is PCI of more than 1 month or ACS of more than 3 months. In that case, you can continue aspirin and stop the P2Y12 inhibitor. So ticagrelor you stop for 3 to 5 days, clopidogrel for 5 days and prasugrel for 7 days. So the guidelines have changed recently. Braunwald follows the 2016 ACC guidelines. So I'll repeat this once more. So patient is on a dual antiplatelet, surgeon feels that he can do the surgery on DAPT, continue the DAPT. The next criteria is PCI of less than 1 month or ACS of less than 3 months. If the patient is in this time interval, try to defer the surgery. If the surgery cannot be deferred, bridge with short acting IV antiplatelets like eptifibatide, tirofiban or cangrelol. Till the day of surgery, do the surgery and then restart the antiplatelets. If the PCI is more than 1 month or ACS of more than 3 months duration, continue aspirin, stop the P2Y12 inhibitor. Okay. So let's say this patient had to undergo a polypectomy as well. Okay, so you are not only doing a colonoscopy, you are doing a polypectomy as well. So in that case, it becomes a bit more controversial. You have to go in for the bridging eptifibatide, tirofiban, and then take him till the day of surgery, and then do the polypectomy, and then restart the aspirin and clopidogrel as such. So post-transplant patient, angiogram is given. So this patient is a 1 year post-cardiac transplant patient, had intermittent dyspnea. And they gave you this angiogram and asked you the following options. Is it a coronary embolism, ectasia, pruning or myocardial bridging? Even if you don't know anything, you will straight away say it is pruning. Okay. This is classical coronary allograft vasculopathy. Okay, coronary allograft vasculopathy, CAV. It's the most important long-term complication after cardiac transplant. So again, this is due to immune-mediated myointimal proliferation, and you have intense inflammatory cell infiltrate. So again, it's just like the pulmonary artery pruning. So you can see The vessels become distal vasculature becoming normal, becoming narrowed because of the myointimal proliferation and the inflammatory cell infiltrate. Again, coronary ectasia is completely different. You can see bulbous dilated coronary arteries. This is coronary embolism. So you can see bubbles embolizing. This is coronary air embolism. Within about 10 to 15 seconds, probably this patient will go in for cardiac arrest. So the stent is being placed here, and during the next injection, air has been accidentally injected into all arteries. This patient invariably will go in for a cardiac arrest. And this is myocardial bridging. So you can see the bridge here. You can see a stent here above. Just below the stent, you can see the vessel being squeezed. This is an IVUS here. So you can see that now you can see this milking effect on the IVUS. Okay, so we have described all this in our videos. So again, coronary pruning, even if you don't know anything, you will straight away mark. Female patient with mid-systolic click and mid-systolic murmur. What are we dealing with? We are dealing with mitral valve prolapse. They are asking you the associations of mitral valve prolapse. High arch palate, hypotelorism, straight back, and inguinal hernia. Again, the answer is pretty clear. High arch Marfan's is associated with MVP. Straight back syndrome is associated with MVP. Again, inguinal hernias can be seen in Marfan's, so it's also associated with an MVP. Actually, the statement is taken straight from Harrison. So read this paragraph. Okay. MVP is a frequent finding in Marfan's osteogenesis imperfecta Ehlers-Danlos. May be associated with thoracic skeletal deformities, high arch palate, alterations in chest and thoracic spine, straight back syndrome, inguinal hernias, joint dislocation, meniscal tests, EC bruisability. Again, a statement taken straight from Harrison. So next patient, severe MS patient, NIHA class 2, AF on anticoagulation with a history of TIA. Valve is stenosed, calcified, LA appendage clot. What is the most appropriate treatment for this patient? Balloon valvotomy, open valvotomy, closed valvotomy, medical management, and continue anticoagulation. Obviously, the valve is stenosed. You need to open up that valve. Valve is heavily calcified, has an LA appendage clot. Again, you won't do a balloon valvotomy for this case. Okay. Obviously, you cannot do medical management and continue anticoagulation because again, it's a severe symptomatic MS with clots. The treatment of choice is open mitral valvotomy. So how do you approach treatment of severe MS? Okay, if this patient has severe MS, your treatment of choice is balloon mitral valvotomy if the valve is pliable. So if the valve is suitable for balloon mitral valvotomy, you do a balloon mitral valvotomy. If you cannot do a balloon mitral valvotomy, you consider open mitral valvotomy. If you cannot do open mitral valvotomy, you consider mitral valve replacement. This is your flow chart. So balloon mitral valvotomy, if the patient is not a candidate for BMV, consider open mitral valvotomy. If the patient is not a candidate for open mitral valvotomy, consider MVR. The problem arises in most centers is surgeons are not skilled in doing open mitral valvotomy. Cardiologists do the balloon mitral valvotomy. Surgeons are not skilled in doing open mitral valvotomy. It is far easier for them to do a MVR. So in most centers, it is BMV done by the cardiologist. If you cannot do a BMV, you send it to the surgeon for an MVR. However, this is not the recommended approach. The recommended approach is BMV, not suitable for BMV, go for an OMV, not suitable for an OMV, go for an MVR. This patient has LA appendage clot. The valve is calcified. You cannot do a BMV. So the next treatment of choice is open valvotomy. Mechanism of tricuspid valve involvement in carcinoid syndrome. So the history was given that a patient presented had flushing, tachycardia, and diarrhea. So features suggest of carcinoid syndrome. And they asked the mechanism of tricuspid valve involvement. So was it an increase in valve area, papillary muscle dysfunction, annulus dilation, fibrous deposits, calcific deposits? So this was the diagram I had put in the lectures. So all the fibrous deposits on the valve, and it's basically entirely mostly right-sided valve deposits. These are fibrous deposits on the valve. So if you remember this diagram, you will straight away answer this question. Okay. Fibrous deposits mainly on the right-sided valve. Carcinoid syndrome is usually a right-sided disorder. So it results in varying combinations of TS and TR and PS and PR. Okay, so varying combinations of TS, TR and PS and PR. Mostly right-sided disorders because your lung is going to filter out all your serotonin. So another question related to the same. Patient took a drug for prolonged period. presented in the OPD with multivalvular heart disease. So which drug can cause multivalvular heart disease? Ergotamine, methyl dopa, orlistat, and cocaine. So basically they're asking for drug induced carcinoid disease. Okay, so basically they're looking for which drug can cause increase in serotonin levels. Fenfluramine and dexfenfluramine cause increase in serotonin levels. Phentermine interferes with the drug metabolism in the lung. So 5-HT is metabolized in the lung. So phentermine inhibits the lung metabolism of 5-HT. Ergot derivatives like ergotamine, methylsergide, pergolide, and cabergoline are 5-HT agonists, are serotonin agonists. So again, they basically mimic an increase in serotonin level. MDMA inhibits reuptake of serotonin. So basically again increases serotonin levels. So basically they are looking for causes of drug-induced carcinoid heart disease. So remember, fenfluramine, dexfenfluramine, phentermine increase the serotonin levels. Ergot derivatives like ergotamine, methylsergide, and pergolide and cabergoline, they are 5-HT agonists. They mimic serotonin usage. And MDMA inhibits the reuptake of serotonin. All of this increase serotonin levels and can cause drug-induced carcinoid. The common pathogenic link is increase in serotonin activity, since many of the drugs and the metabolites are potent 5-HT receptor agonists. So in this, it is ergotamine. So 2 questions from carcinoid. In this paper, I feel that restrictive cardiomyopathy was the most important chapter. So which of the following is true for coarctation of aorta? Greater than 20 mm greater in the presence of extensive collaterals, rib notching in the upper borders, left arm should be used to measure blood pressure, diastolic tailing in thoracic aorta. Again, something was given in the abdominal aorta also, but we don't have that option. So if you have extensive collaterals, there is going to be no gradient. So suppose you have a coarcted segment here and you have extensive well-developed collaterals. Okay, blood will flow through the collaterals, there will be no significant gradient. Rib notching is seen in the lower borders of the 3rd to 8th ribs, not the upper borders. You should measure pre-coac as well as post-coac segments. So you should measure BP in the upper arm as well as the lower limbs. Okay, so in order to confirm, in order to detect coarctation of aorta. Diastolic tailing is seen in thoracic aorta. This is something we have dealt with. So rib notching in the lower ribs, this is from my charts, lower ribs, it's called as Rossler's sign or Dock's sign. So posterior 1/3 of the inferior border of 3rd to 8th ribs caused by erosion by the large posterior intercostal arteries. So significant gradient is more than 20 millimeters, and characteristically you have this diastolic tailing. Again, this is from my videos. So diastolic tailing is the answer. So pulmonary embolism in pregnancy, next investigation of choice. So again, it's said that this patient had a high Wells score. Answer is VQ scan. VQ scan is seldom. I have yet to see a patient undergo a VQ scan. I have yet to see a center have a VQ scan, but VQ scan has its role. The role of VQ scan is to identify pulmonary embolism in pregnancy. So remember, CTPA is contraindicated in pregnancy. In renal failure patients, so you're putting a dye. So this dye is excreted to the kidneys. So especially the dye can cause contrast-induced nephropathy. And number 3, allergy to contrast. These are your 3 indications for VQ scan in pulmonary embolism. Again, dealt with in the videos. Cardiac sarcoid, most common presentation. Again, it is biventricular failure. Straight from my videos. So again, this is from my lectures. I've said that DCM with biventricular failure is your most common presentation. You can have varying combinations of VT and VT-VF and AV blocks. So you can have DCM, you can have DCM plus VT plus AV block. You can have DCM plus AV block. You can have DCM plus VT. You can have AV block plus VT-VF. So all of this can occur in varying combinations, but your most common is DCM with biventricular failure. I have told you RCM is rare. It is possible but rare. Amyloid presents with RCM. Again, other manifestations also I have told you, but I have specifically mentioned DCM with biventricular failure is your most common manifestation. 4th question from the same chapter. in restrictive cardiomyopathy. ICD indicated in asymptomatic HFrEF patients. True about cardiac sarcoid. ICD indicated in asymptomatic HFrEF patients. LG in apical septum. Angina is a common presentation. Heart block is a rare manifestation. Heart block is common. Angina is not your most common one. It is DCA with biventricular failure. LG is present in your basal septum. So this is the diagram for cardiac sarcoidosis. I have told you the basal septum is involved. Your conducting system passes through the basal septum. The granuloma which is here can compress upon the conducting system and can cause AV block. I told you basal septum is involved, not the apical septum. And ICD is indicated in asymptomatic HFrEF patients. This is also true. Okay, again, there is no standard guideline for asymptomatic patients. For class 2, class 3, you have a guideline. When it is class 1, there is no standard guideline, but it is definitely recommended for by many bodies because cardiac sarcoidosis has a very high risk for VT and VF. So these were the guidelines how you treat cardiac sarcoidosis. So this is from the American College of Cardiology, from this guideline which came out in 2022. Almost all patients with clinically manifest sarcoid will benefit from ICD. Okay. Patients with cardiac sarcoid who do not present with the class 1 or class 2A indication, that's why I said typical indications, still have a 5% risk of sudden cardiac death, and ideally all patients are appropriate candidates for ICD. I have mentioned in my videos that patients have a high risk for VT and VF. Generally, you prefer putting in an ICD. Okay, even if the patient presents with an AV block, these patients are still at high risk for VT and VF. That's why you avoid putting pacemakers alone. You put in an ICD. Remember, an ICD will also pace. Okay, so ICD is indicated in asymptomatic HFrEF patients. This is true for the most case. Look at the guidelines. The guidelines will say it is you require functional class 2 and functional class 3. But that's why I said practically, even in functional class 1 patients, you would almost always put in a ICD. Okay, which OHA helps in reducing heart failure, hospitalization, and better renal outcomes? Again, it has been repeated 100 times. This is the SGLT2 inhibitors like EMPA and dapagliflozin. So you have various trials for this. Okay, for the cardiac benefit, you have the EMPEROR Preserve trial. Okay, you have the DELIVER trial, which the EMPEROR Preserved is for empagliflozin in HFpEF. DELIVER trial is for dapagliflozin in HFpEF. You have the EMPEROR Reduced trial. You have the DAPA HF trial. So the EMPEROR Reduced trial is empagliflozin in HFrEF. DAPA HF trial is dapagliflozin in HFrEF. Again, for CKD also you have various trials. Okay, you have the EMPA kidney trial. Okay, which the benefits of empagliflozin in renal failure. Okay, we have the SCORE trial. Okay, there are lots of trials. So anyway, there's absolutely no controversy. It has been described a number of times. So the drug reducing heart failure hospitalizations and better renal outcomes is an SGLT2 inhibitor. So increased CVP on increased central venous pressure on JVP, bounding, this is pulsations. Bounding pulsation in the neck and eyeball pulsations. What are we dealing with? Dealing with tricuspid regurgitation. So this is a JVP. You can see a very prominent CV wave. It is this CV wave, the expansile CV wave, or so called the venous corrigan, which causes everything to have systolic pulsations. So you'll have systolic pulsations in the neck. It is called as venous corrigan. You will have systolic pulsations of the earlobe. You will have systolic pulsations of your eyeball. You will have systolic pulsations of your liver. In fact, you will have systolic, your veins may become dilated and tortuous. You will have systolic pulsations of your vein. All of these are manifestations of elevated RA pressure. The prominent CV wave. Okay, this was the prominent CV wave. You can see the venous corrigan here. The same thing can be seen in the earlobe, in your eye. Again, it's a very simple question. The answer is tricuspid regurgitation. You're dealing with a prominent CV wave of TR. POTS, increase in heart rate. So again, I've told you 30, 20, 10. POTS, it is increase in heart rate of more than 30. For postural hypotension, it is systolic BP fall of more than 20. and SBP fall of more than 20 and diastolic BP fall of more than 10. So 30, 10, 20, 10 rule. So again, from my slide, spots 30. For postural hypotension, it is 20 by 10. Systolic of more than 20, diastolic of more than 10. A relatively simple question. So again, it's a medicine topic. Unfortunately, they mentioned cardiac failure here, so I have to deal with it. The question goes something like this. You have an elderly female who was fasting for a very long time. Okay. Then was started on carbohydrate meals with adequate calories. Patient developed cardiac failure within 24 hours. So elderly female fasting for a very long time, started on a carbohydrate meal with adequate calories, developed cardiac failure within 24 hours. The cause is hypophosphatemia. So what are your nutritional causes of cardiomyopathy? Wet beriberi caused by thiamine deficiency. Is it common? It is seen occasionally. So the common situations that I have seen is pregnant females with hyperemesis gravidarum. They keep on vomiting, develop thiamine deficiency. Alcoholics with a very poor dietary intake. Number 3 is teenagers repeatedly only taking processed foods. So these are your 3 common situations I've seen. Abnormalities of carnitine metabolism. Selenium deficiency causes dilated cardiomyopathy. Okay, it causes an endemic DCM in China or Southeast Asia. This is called as Keshan's disease. So endemic cardiomyopathy mostly in China presenting as a DCM. Okay, it's called as Keshan's disease caused by selenium deficiency. Hypocalcemia. Okay, classically seen post thyroid surgery. So the heroic surgeon removes the thyroid, chops off your parathyroid also. Patient goes in for recurrent hypocalcemia. Do his echo after 1 month, you will see DCM. Okay, and this responds dramatically towards calcium supplementation. Harrison also mentions that in chronic diarrhea as well as in post removal of a large portion of your intestine, and hypophosphatemia as seen in refeeding syndrome. So what are electrolyte abnormalities in refeeding syndrome? They are hypomagnesemia, kalemia, hypophosphatemia, thiamine deficiency, and salt and water retention. Out of which hypophosphatemia is your hallmark for the syndrome and a predominant cause of refeeding syndrome. So what happens is, phosphate, remember, is an intracellular ion. Okay, so when you give a high carbohydrate meal, so if the patient is fasting for a long time, all your stores of phosphate are depleted. So when you give a high carbohydrate meal after fasting, your insulin levels are going to shoot up, and insulin drives phosphate into the cell. Okay, insulin drives phosphate into the cell, and so insulin drives phosphate intracellularly. Okay, insulin also creates more ATP and 2,3-BPG to be formed. So increase in ATP and 2,3-BPG. Again, these are phosphated compounds. So already the phosphate is being pushed into the cell, and the phosphate is also directed towards producing ATP and 2,3-BPG. Thereby there is phosphate deficiency is created, and this causes cardiomyopathy, rhabdomyolysis and all. So again, most fatalities that occur in refeeding syndrome are due to cardiac complications such as due to impaired myocardial contractility, stroke volume, heart failure and arrhythmias. Again, I feel this is more of a medicine question, but since they have mentioned cardiac failure, I am dealing with it. So remember, refeeding syndrome, hypophosphatemia is your characteristic abnormality, and hypophosphatemia can lead to cardiac failure. With this, we come to the end of the recall session. So I hope you had a very good paper as such, because I felt that cardiology as such was a much higher standard when compared to the last year's NEET SS. It is a much higher standard. You had more factual questions. So you had the all or none law. You could not sit and guess the answers out. So the overall impression I've got from the Zoom discussions which we had was the entire paper with all subjects was of a far higher standard. So I think you should be happy that you've got a higher standard paper. So but I always say, if you get a high standard paper, it selects out those who have studied very well. Okay, so hopefully you have done well and you will secure a seat in your dream branch. Thank you.